On the morning of June 3, 1985, a breast cancer patient walked into the Kennestone Regional Oncology Center in Marietta, Georgia for her 10th radiation treatment. The plan was simple. 5 minutes under the machine, then home for lunch. The technician set the dose. The machine hummed. And the patient felt a deep burning sensation between her shoulder blades, a heat she had never felt in any of the previous 9 treatments. She told the technician. The technician checked the machine. The readout said the treatment had delivered a normal dose of 200 rads. She went home. 4 months later, she was dead. She had not received 200 rads. She had received something closer to 15,000. 75 times the intended dose. A radiation burn so severe that it killed muscle, destroyed nerve, and eventually killed her. The machine that killed her was called the Therac-25. Over the next year and a half, it would overdose 5 more patients across North America. And the reason, the single engineering decision that made it possible, is still taught in every university software safety course today. The Therac-25 was a linear particle accelerator built by Atomic Energy of Canada Limited, AECL, a Canadian Crown corporation. It was designed to treat cancer by firing beams of electrons or X-rays at tumors at carefully controlled doses. It was the successor to 2 earlier machines, the Therac-6 and the Therac-20. And those earlier machines had something that the Therac-25 would not: hardware interlocks. A hardware interlock is a physical mechanism, a metal bar, a sensor, a switch, that prevents a machine from firing when it is in a dangerous state. On the Therac-20, if the beam target wasn't correctly in place, a hardware interlock physically blocked the beam from firing. It was mechanical. It could not be overridden by a software bug. It simply was not possible to deliver the wrong dose. When AECL designed the Therac-25, they made a decision that saved them money. They removed the hardware interlocks. They trusted software alone to keep patients safe. The software that ran the Therac-25 was written in assembly language on a PDP-11 minicomputer. By one programmer. Alone. There was no formal code review. There was no systematic testing against failure modes. Large portions of the code had been inherited directly from the Therac-20, where the hardware interlocks had been silently catching any software mistake for years. The bug was a race condition. The machine had 2 modes, low-energy electron mode, and high-energy X-ray mode. X-ray mode required a metal target and a beam spreader to be physically moved into position, a mechanical process that took roughly 8 seconds. If an experienced operator typed the prescription fast, selected X-ray mode, then pressed the edit key to correct it to electron mode, all within those 8 seconds, the software got confused. It thought the machine was in electron mode. But the magnets and the target had not finished moving. Which meant that a beam designed for 25 million electron volts of high-power X-ray generation fired directly at the patient, with none of the attenuation required to make it safe. 100 times the intended dose. Sometimes more. When this happened, the machine would display a cryptic error, malfunction 54. Operators saw malfunctions on the Therac-25 all the time. Most of them were harmless. The manual did not explain what malfunction 54 meant. So operators did what operators always did. They pressed the P key. P for proceed. And the machine fired again. The Kennestone patient was the first known victim. Georgia, June 1985. AECL investigated. AECL said the machine was fine. AECL said the operator must have made a mistake. 6 weeks later, a patient in Hamilton, Ontario received a similar overdose. She died 3 months later of radiation-induced complications. Then a patient in Yakima, Washington. Then, 4 months later, another patient at the same Yakima clinic. Each time, AECL denied. Each time, they blamed operator error, wiring faults, static electricity, anything except their software. They issued minor tweaks and sent letters reassuring hospitals that the machine was safe. Then in March 1986, at the East Texas Cancer Center in Tyler, a man named Ray Cox walked in for his 9th radiation treatment. The technician, an experienced operator named Mary, typed the prescription fast. She accidentally selected X-ray mode. She noticed. She pressed the edit key and corrected it to electron mode. She hit return. 8 seconds had not yet passed. The race condition fired. Ray Cox later described what he felt as an electric shock slamming into his back. He jumped off the table, ran out of the treatment room, and collapsed in the hallway. Inside the control booth, separated from the treatment room by thick concrete walls and with no intercom working that day, the technician saw malfunction 54 on her screen. Seconds passed. She knew nothing was wrong. She pressed P to proceed. The machine fired a second time. Ray Cox suffered massive radiation damage to his spinal cord. He lost the use of his left arm and both legs. He died of complications 5 months later. 3 weeks after Ray Cox, at the same clinic, another patient became the 6th victim. He died within a month. And this time, the clinic's in-house medical physicist, a man named Fritz Hager, refused to accept AECL's explanation. He took the Therac-25 offline. He started experimenting. He reproduced malfunction 54 himself by deliberately typing the prescription the same way the technician had, then editing it within the 8-second window. But it was a software safety researcher named Nancy Leveson, working with engineer Clark Turner, who published the definitive analysis in 1993. They didn't just identify the race condition. They identified the root cause, a decision-making culture at AECL that treated software as inherently reliable. A culture in which a single programmer, writing assembly code alone, without reviews or formal testing, was considered sufficient guardianship of lives. In 1987, after 3 deaths and 3 more maimings, the FDA finally forced AECL to recall the Therac-25. The fix was not more elegant software. The fix was a hardware interlock. The same kind of mechanical safeguard that had quietly been catching software bugs on the Therac-20 for almost a decade. The Therac-25 incidents became the founding case study of modern software safety engineering. They directly seeded the IEEE 62304 standard, the international regulation that today governs how software is built for every medical device on Earth. Every pacemaker. Every insulin pump. Every surgical robot you have ever encountered exists inside a regulatory framework whose skeleton was built from the autopsies of Therac-25 victims. The lesson is brutal and simple. Software can be tested. Software can be reviewed. Software can be formally verified. But software alone, standing between a machine and the death of a human being, without a physical mechanism that can stop it when it fails, is a bet against randomness at a scale no engineer should accept on someone else's behalf. Between June 1985 and January 1987, 6 people were overdosed by a machine designed to save them. 3 of them died. 3 more lived the rest of their shortened lives in pain and disability. Their names are now footnotes in 100 engineering courses. And somewhere inside the code base of a device that you, or someone you love, will depend on someday, there is a line of logic that has never been exercised. A malfunction 54 waiting to be discovered the hard way. Thanks for watching. If this story was worth your time, subscribe.